Okay, so dear colleagues and friends all over the planet, usually when having a webinar, it is a less direct way to communicate, but these are special times for all of us, so I would prefer seeing it as an opportunity for unity. This is my sentence for you. And although we are far away and most of us are quarantined, I feel that we are all closer than ever, and this is also the time for development, learning, and improving. So we come stronger when all this corona situation is over. So having that said, I will present myself. My name is Dr. Michael Abba. I'm an oral and maxillofacial surgeon from Israel. I work as an attending at the maxillofacial department in Ashkelon Medical Center, which is a few kilometers from Tel Aviv. So this is our hospital, and as you can see, this is our team. And as a referral center, we get many cases of complications from the community. And one of the most invasive procedures we perform at our private clinics is the sinus lift procedure. And if you look at these two numbers, this is the statistics for a sinus lift to develop a complication. So basically, 1 of 20 patients that come to our clinic will have a major complication following this procedure. And why do I say a major complication? As you can see, and look at this picture, this is a pretty common presentation after open sinus lifts. And a major complication would be a complication that has a negative impact on the quality of life of the patient for a long period of time. And unlike other procedures we perform, there can be significant symptoms. As you can see, these patients have hematoma, they have prolonged swelling, they can have headaches if there is sinusitis, pus discharge, nasal congestion, and sometimes they also need general anesthesia. And remember, this patient came to our clinic only for a dental treatment, and then we sometimes need to tell him, okay, sir, we need to perform a general anesthesia because you have infection of the sinus. So in the presentation today, I will review the diagnostic steps in order to minimize the potential complications of the sinus lift surgery, and I will present the multidisciplinary workflow for managing these complications. And before each treatment plan or surgery, I usually ask myself 3 questions. These questions would be what, why, and how. When I'm talking about what, it is very important to know what are the potential complications we can have in this specific procedure. When I'm asking myself why, this is basically the diagnostic step. Why these complications have a high risk in this specific procedure we're going to do. And maybe the most important question would be the how. How do I manage these complications? And I need to tell you personally, today, if I am not sure how to manage the complication, sometimes I prefer not performing the procedure. So let's start with the first question. What are the most common complications in the sinus lift procedure? They are separated in intraoperative and postoperative complications. And the postoperative complications, again, are divided into short and long term. And if we talk about the intraoperative complications, there are a few, but the most common are membrane perforations and bleeding. There's also implant displacement, implant instability, bone overfill. And the postoperative complications The short-term ones would be swelling, hematoma. There can be nosebleed. We need to tell this our patients. Maybe sometimes soft tissue dehiscence if we have a large augmentations, maybe outside the sinus. And purulent secretion that can happen even in the short term. And in the long term, we have infection and chronic sinusitis. And of course, the symptoms are purulent secretion, nasal congestion, graft discharge, chronic pain, and as we said before, need for general anesthesia. So moving to the second question is why complications happen. This is basically the diagnostic step. So for each patient that comes to a sinus surgery, I would ask some screening questions. If you ask the patient, okay, sir, do you have sinusitis? Usually you will get an answer, no, I don't have a sinusitis, because not everyone knows what their symptoms are, are addressing to. And I had this presentation in a meeting, and at the end of the presentation comes to me one of the organizers, and he's telling me, wow, now I know what I suffer. I always have nasal congestion, and I have purulent drainage inside my throat, and I didn't know that I suffer from sinusitis. So these are the basic questions I ask, and sometimes the patient says, no, I don't have sinusitis, but he answers these questions, and eventually it turns out that he's suffering from a sinusitis, and sometimes for a long time. And the diagnostic part is not full unless we perform also a surgical diagnosis, which is based on the anatomy. And I will review the anatomy. I will emphasize only the important structures for our discussion today. And I will show you my multidisciplinary approach. So the surgical anatomy, if you look at the basic anatomy of the sinus, has 5 walls, but I am interested specifically in the medial wall, which has some very important structures. It is the connection of the maxillary sinus to the other sinuses, the frontal, the sphenoid, the ethmoid, and this is the reason the infections are not localized. They have a generalized form. Okay? And the most important structure in the medial wall is the OMC, the osteomeatal complex, which drains the sinus. Now, this is something that I learned from my plumber, and yes, my plumber. And if you look at any drainage system, eventually, it works together with gravitation. So this is not the case for the maxillary sinus. As you can see, the drainage system in the maxillary sinus goes to the upper side, not with the gravitation. So the OMC, which is the drainage of the maxillary sinus, in the upper medial part of the sinus. And the direction of the drainage is towards the OMC. There is a special respiratory mucosa, which is called cilia, and moves debris toward the meatus. As you can see on the right side video clip, you can see that the mucus is moving up to the drainage system, and this is very interesting because I accidentally saw this finding. I was editing this video clip and having it fast forward, and suddenly I noticed that you can see the movement of the mucus up towards the meatus. So this is a very important point to remember, because sometimes we can see that foreign bodies in the sinus have the tendency to go up. And this is not because this patient is doing a headstand. Okay? He's walking, but although he is walking and standing, the foreign bodies go inside. So look how powerful this cilia is, the movement in the maxillary sinus. So Now we can move and see the blood supply. The blood supply comes from the maxillary artery and the infraorbital artery, and our interest is in the intraosseous anastomosis in the lateral wall. And in the work we did, it was published at the Jones, we found that almost a third of the intraosseous anastomosis can be of significant size and interfere with the procedure. We will see it in a few minutes. In order to do this diagnosis, we need to do imaging. So, what would be the best imaging modality for the maxillary sinus surgery? So if you look at this panoramic X-ray, I wouldn't say there is a significant pathology in this X-ray. But the patient comes and he complains about nasal discharge, bad smell, headache. So we decide to send this patient to a CT scan. And look what we see in the CT scan. This reveals the whole picture. So basically, we must remember that CT is the gold standard, and there is no sinus surgery I would perform without doing a CT scan before I start. So if you look, there's obvious sinusitis in the sinus, there's inflammation, there is bone loss, and this patient had to go to general anesthesia. And now look at the CT scan. Usually we send our patients to the X-ray lab, and they send us this CT scan, and we operate by what they send us. So I'm asking, who would perform open sinus lift in this case that is based on this CT scan? The sinus looks clean. There is no membrane thickening, no symptoms. But you need to remember, I will not perform any surgery based on this CT scan. If you look at the CT window position, we always must see the osteomeatal complex in the CT scan. So I call the X-ray lab and tell them, okay, I want to have it a higher view of the sinus, and as a rule of thumb, I would usually tell them I want to see the inferior orbital wall, because usually when I see it, then part of the nose, and then they position the window so we can see the drainage of the maxillary sinus. So, as an example, you can see this is the initial diagnosis in this case. We look at the CT scan, there's a little bit of membrane thickening, but not something special. And this is the CT scan that the operation was based on. And the operation was done, and after a few months, this patient started developing sinusitis symptoms. Headaches, nasal congestion, pus discharge. So, we send this patient for a CT scan. And this is what the CT scan reveals. There is a pansinusitis which fills the maxillary sinus, the ethmoidal sinus, and also the frontal sinuses. And then I go to my first question, and I ask myself, why do this complication happen? And then I go again to the CT scan, and I call the lab and tell them, please change the position of the window of the pre-surgical CT scan. And they change the position and they send me all of the data they have. And I tell them, if you have, please send me all the coronal pictures. So you can see that the full picture is this. We can see there is an ethmoidal sinusitis and the osteomeatal complex is blocked. So if I would have seen this presentation before surgery, there is no way I would perform any surgical procedure upon this maxillary sinus, because it will usually fail. But there are many things we need to see in the CT scan before we begin our surgery. And now I will review all the landmarks that must be diagnosed and noticed in the CT scan. So I would call it a radiologic checklist. Okay? So the first finding will be the presentation of the sinus, whether it is clear or filled. Any operation done under this situation of sinusitis is more likely to fail, as we said. So this sinus must be treated, as you see in this picture. The left sinus, must be treated before performing a sinus lift. I'm not talking about why this patient has a sinusitis. We will talk about it later. But in any case, as you can see, it is very obvious that you cannot operate on this sinus. The second finding would be thickness of the membrane, which can be indication of sinus inflammation in different stages. Usually a circumferential thickening would be a clue for unhealthy sinus. The normal thickening is said to be around 1 millimeter, 1 to 2 millimeters, and pathological swelling is more than 2 millimeters. This is not always the case, but is just a general indication. So when I see a circumferential thickening, I will usually make a thorough questioning of the patient. First, I will ask all the questions, and I will talk with the X-ray lab and tell them, ask them for a full coronal CT scan and consider an ENT evaluation. When I see this finding, I ask the patients about recent illness, and I make a thorough questioning. Another finding we can see, these are the mucous retention cysts, which are called polyps. So this is basically localized swellings of the membrane, and the meaning of this finding is that when we perform our augmentation, we lift the membrane, we do our augmentation. So if it is a large polyp, we may block the osteomeatal complex with this polyp. And usually it is said that cysts that are larger than a half of the vertical height of the sinus must be treated before performing the surgery. So I recommend these cases to treat before the surgery itself. And there are techniques. There's a special technique I'm using. I call it the double window technique, in which I remove the cyst intraoperatively, and I do the sinus lift in the same surgery. Now, what I would like to emphasize, that most of cases that I see that clinicians aspirate these cysts, and then they perform the surgery. But aspiration is not enough. Remember, this is a cyst. If you do not remove the cyst, this will fill again. So there's no point in just aspirating. You have to remove the cyst before performing the surgery. And I will show you a short video clip with the technique I'm using. So as you can see, I perform a window and I leave a small bony fragment in the middle of the window. And then I aspirate this fluid. And after I aspirate it, I remove the cyst from the small window I created in the membrane itself. As you can see, I remove the cyst. And after removing the cyst, the small window in the membrane can be used to block the opening, and I can continue and do the surgery. As you can see, the membrane is moving. So if the membrane is moving, the membrane is intact, and I can continue and perform my sinus lift. Now, all of these three findings would represent a disruption of the normal physiology of the sinus and require an evaluation and treatment before performing the sinus lift procedure. If we decide for an intervention, a fast surgery can be performed by an ENT surgeon. This is an endoscopic intervention that removes any pathology from the sinus, and basically what it does, it enlarges the OMC, and there is also a second option to perform a special implant that is called DIVA. It is not available now in North America, but I will show it later just for you to know the technique. It is a very interesting technique. Now, we will see now a short video clip of a fast surgery, and as I see it, as I call it, a multidisciplinary approach. It is very important to see what happens from the inside of the sinus when we perform a sinus surgery, because then we have a full understanding of the procedure we perform. And this improves our performance during the surgery. So in this case, we decided to perform a FES, and then one stage perform an implant after cleaning the cyst, removing the cyst from the sinus. I showed you before how I do it. Most of the cases I remove the polyp intraoperatively, but the standard way is doing it before the surgery, the sinus surgery, and remove it through a FES surgery. So let's look. FES surgery, basically we introduce an endoscope through the nose, and you can see the medial concha. And this is the Unzinet process, which covers the osteomeatal complex. And this area is removed by a debrider. And after we remove this area, we can see that we gain access to the maxillary sinus. So this is how it is done. As you can see, this is performed in general anesthesia. This is not minimal invasive, and you can see the cyst inside the sinus. In this case, we're using an endoscope. It's a 70 degrees endoscope, and we can see the cyst. And then we have a special forceps, which we see the polyp itself, and we remove the polyp from the base of the sinus and remove it through the nose. As you can see, you can appreciate it. This is not a small cyst, it is a pretty large cyst. And after we remove it from the nose, we can continue our procedure and perform a closed sinus lift in this case, using the osteotome technique. And we can also observe the procedure from inside the sinus during our surgery. Now, another finding that we need to notice at the CT scan before the surgery is the thickness of the lateral wall, which is an indication for me how hard is going to be this procedure, this specific procedure. Again, why this is the diagnostic step, why this can happen in this specific case. If we have a thick wall, then we need to do window modification. We can thicken the wall before we open the sinus. And in any case, doing a trap door is going to be very, very hard. So we need to plan this before surgery, not come to the surgery and see, oh wow, I see this is very, very, very thick bone. And in the contrary, if we have a thin wall, then I would expect is membrane perforation, and I need to be ready for it, because I know, as you can see in this area, you can see that this is a bluish area in the bone. I didn't touch it. There's a bluish area in this area because the wall is very, very, very thin. And if I put my burr there, there's a high chance that I will go directly inside the sinus. So I need to be ready for this. And another finding, as I mentioned before, this is the intraosseous anastomosis. As you can see it here in this area, this is not a very large one, but this can interfere with the procedure. So you can see in the next video clip, you can see the procedure and the blood vessel itself that can be seen here in the lower part. As you can see, there can be really pumping of blood from this artery, and it can interfere with the procedure. I cannot continue with the procedure until I stop the bleeding, and I use electrosurgery. And usually, when you use electrosurgery, when you have such bleeding, you may have also membrane. There's a high chance you will have a membrane tear, and you need to be ready for this. You need to be able to continue the sinus lift, although you have a membrane tear, and you need to be ready with adequate equipment. You need to have your membranes. You need to have the skills to close this perforation. And if I'm able to do it, I will continue the procedure. And this is a regular sinus lift, and we just finish it. Another finding that is an important factor before the surgery itself is the width of the maxillary sinus itself. In case we have a narrow sinus, we need to know that we need to avoid performing the trapdoor, because the medial wall will interfere with the lifting of the membrane. And usually when I see that I have a very narrow sinus, I know this is going to be a hard case. And this is something that I need, first of all, to know, prepare, and also explain the patient. In contrary, when we have a sinus that is wide, the most mistake is that it is underfilled, because it is much harder to gain access to the medial wall. So again, we need to know this is the situation, and sometimes use more bone graft and gain access to the full width of the sinus. Septas are very common finding. It's about a third of the cases we will see septas, and this is one of the most common causes of membrane tears, and usually I would prepare myself for these tears in these cases. And there are two kinds of septas, transverse and longitudinal. And again, there are ways to deal with these septas. We need to be ready for it. Otherwise, we perform our sinus lift and we don't gain access to the full volume that I need to perform the augmentation in order to place the implants. So this is a very, very special situation, common, and I need to be ready to deal with this situation. And last would be the sinus floor irregularities. When I see this situation, again, I know that I will have hard times. It is going to be much harder to separate the membrane, and I will tell the patient, okay, listen, in this case there is a high chance of perforation. There is also a high chance, there is a chance that I will not finish the procedure, and the patient must be ready for it, because you need to remember that this patient came. Sometimes you do it under sedation, under anesthesia, and he comes, we do the procedure, and then we tell them, okay, I'm sorry, you need to come again after 6 months and do the procedure again. And you need to explain this to the patients, because this is the only difference between an explanation and excuse. It is the timing. If you explained before the surgery, then this is an explanation. But after the surgery, if you didn't explain, this is an excuse. And this is a very, very important thing to remember. And we need to be ready. For any case, we need to, in case of bleeding, we need to have electrosurgery, we need to have sometimes bone wax, tranexamic acid, and use all the equipment needed for dealing with the complications. Membrane, in case we have a membrane perforation, and also we know that membrane perforation and success are related to each other, and perforated sinuses have high risks to fail than not perforated sinuses. Another complication would be implant displacement. As the lower bone height is, it is more common to have implant displacement inside the sinus, and again we need to explain the patient that this case we may do a two-stage procedure because of the available height of the bone. So we consider a two-stage procedure. Okay, so by now we were talking about the intraoperative complications, and now we move to the postoperative complications, which are the immediate complication would be a soft tissue dehiscence, which is needs to have a tension-free closure in order to prevent this complication. Sometimes we have a graft discharge outside of the sinus. It sometimes depends on the angle of the buttress, and this is also a complication that we can have. And also bone overfill that blocks the osteomeatal complex, and inevitably it will cause sinusitis if it is blocked. And you also need to remember that we don't need a lot of bone. We need just the bone for placing 13 or, if you prefer, 16 millimeters implants. Infections after the surgery, this is the most common complication. And usually these patients have a fistula, and they have also a pus discharge. And first, I would use antibiotics and penicillin with clavulanic acid, sometimes Metrogel, and we can consider, if there's no improvement, changing to other antibiotics like fluoroquinolones, the third generation of fluoroquinolones. And I would usually start as soon as possible with this protocol, but I will not wait. I will not wait a lot of time. We need to have immediate treatment in these cases to open the osteomeatal complex. Otherwise, it will transfer to be a long-standing sinusitis, which is much harder to deal with. So now I will take you through my protocol of dealing with sinusitis cases. Now, what I want you to understand that I separate two situations. First one, I call it pre-surgical sinusitis. What I call a pre-surgical sinusitis is a sinusitis which happened before our surgery. This patient came to our clinic, we do the diagnostic step, we do imaging, and we see that he has a sinusitis. And the other situation, I call it post-surgical sinusitis. That means that I've done the surgery, or this patient was referred to me after performing the surgery, and he developed a sinusitis after a surgical intervention in the sinus. These two situations have different etiologies. The pre-surgical sinusitis can be from a dental etiology or a non-dental etiology. And the post-surgical sinusitis could be because of a foreign body, which can be an implant or bone graft inside the sinus. Maybe sometimes implant failure. The sinus is okay, but the implant is not osseointegrated, and the implant develops an infection, and it infects the bone graft and the sinus itself. And sometimes there is an osteomiatal complex obstruction that from any reason. So now let's start and see each of these cases, how we treated them. So first we will start with the dental etiology. We are going to go in and see how I deal with every one of these cases. So we can see that this case has a sinusitis, and this is because of this tooth. As you can see, there's a periapical cyst or lesion here, which causes infection inside the sinus. And of course, we need to extract this tooth because this is the cause of the sinusitis. After we extract this tooth, we need always to think, always to plan ahead. We need to close the sinus because we have a high chance that we have a communication between the sinus and the oral cavity. So if primary closure is possible, we will do it. But if primary closure is not possible, and there is maybe a large oroantral communication, then we need to prepare to close it, and we will close it with a buccal fat pad. There is also a possibility to perform a combined approach, which is a FES and intraoral approach in general anesthesia, in which we clean the sinus through the nose, as you saw before, and then we also extract the tooth and close the communication intraorally. And if it is not resolved after we've removed the infected tooth, the dental etiology, then we have a non-dental etiology. If the sinusitis persists, this is a non-dental case. Now I will show you a short video clip after the extraction. This is the same case, and you can see how I deal with this complication intraoperatively, and you can see after I extract the tooth, look how large the defect is, and I always rinse as much as I can, and then I go to the buccal fat pad area, and I release the buccal fat pad, which is basically an axial flap. It has its own blood supply. As you can see, I release this tissue, and then you can see the blood vessels in this tissue, and I fixate this tissue to the defect, and then I close. So this is the case before the surgery. As you can see, this is after the surgery. The sinus is clean, and we are ready to perform an open sinus lift. Now we move to a non-dental etiology. This patient comes to us before the surgery, and we do the imaging, and we see that this patient has sinusitis. This is a case that I decided to put here. This is also two situations. There is the oroantral fistula present or oroantral fistula not present. As you can see, in this case, there is an oroantral fistula. In this case, there's no oroantral fistula. The bone is intact, but he has sinusitis. You can see this is a long-standing sinusitis. There is also deviation of the septum here. And in this case, non-dental etiology, we have two options. If there is an oroantral fistula, a communication between the sinus and the mouth, it depends how large it is. If it is less than 5 millimeters, we can perform a FES surgery and we can expect spontaneous closure. But if it is a large communication, we need to perform a combined approach. If it is a non-oral antral fistula, then we use the sinusitis protocol. And we can perform a fast surgery in general anesthesia, or use a special implant, which is called the DIVA implant, dynamic implant valve approach, which I will introduce you this technique. And again, as I said before, it is not available in the North America. So this case was treated by this implant, special implant. The implant is placed, as you can see, there is a resolution of the sinusitis, and after a few weeks, we can perform the surgery. And in this case, I will show you how the procedure is done. Basically, it is an implant that has a hollow structure, and we can introduce a needle and aspirate the sinusitis. And this is the situation after we aspirated the pus inside the sinus. You can see the fluid level decreases, and 4 weeks postoperatively, and after healing of 2 months, we can see that the sinus is clear, and we are ready to perform a sinus surgery. Now we will move to the post-surgical sinusitis. Now we're dealing with this side. We performed our surgery, and there is foreign body. There's free graft in the sinus, or there can be implants in the sinus. So in this case, first we consider antibiotics. Sometimes it is self-limiting, and if it doesn't work, we can do lavage and partial removal of the bone graft. But if we see that it doesn't help, then we need to do total removal of the bone graft. As you can see in this case, this is a case that was operated, and this lady suffered with a bad smell and pus discharge, and she had a few operations that were done to close the fistula. As you can see, there is oral antral fistula and pus discharge, and in this case, it doesn't matter what you do. If you try to close it, it will not help because the infection in the sinus. So there is no way just to open the flap. This is not so easy. We need to keep the mucosa, and you can see that we remove all the infected bone graft from inside the sinus. This is basically granulation tissue, and she has a really large defect with the lateral wall of the sinus. You can see the sinus lining inside the sinus. It is very important not to scrape it. And the same procedure, we perform a buccal fat pad. We fixate to the lateral window, but we need to remember that this lady wants to have implants, and this tissue will not transform to bone, and we need to have a second surgery to perform this operation. And after waiting I think we waited here 4 months, I do the second surgery, and I'm planning a bone graft. As you can see, this separation of the fatty tissue from the flap, this is also not so easy. You need to have some experience. And then I thicken this tissue because it usually has a thickness that we don't want. And I do a sinus lift procedure, and you can see that the membrane is moving. And I need to take a bone graft. The bone graft, in this case, I decided to take from the ramus. And I perform the harvesting of the bone graft after measuring the defect using piezosurgery, taking this cortical bone, separating it, removing it, adapting it to the recipient site. This is just a regular bone harvesting, and then we adapt this cortical bone to the maxilla. We adapt it, we use a mesh, and I fixate it to the window. As you can see, I perform the sinus lift surgery inside the sinus, and outside I place the cortical bone, fixation screws. I use the bony chips and grind them and add them to this site. Place a membrane and finish the procedure. And this is the post-operative view. And 6 months after the implant placement, we perform the implants. We need to remove this mesh and perform the implants. Again, we will not go through all this procedure. This is a regular procedure. So if there are implants inside the sinus, then if they are positioned in the lower part, in the lower third of the sinus, we can remove them intraorally endoscopically. And if they are positioned in the upper part, as you can see here, this implant migrated just to the nose, it's much easier to remove them from the nose by FES surgery. And if you can see this situation, these implants are located in the lower third, and we remove them intraorally. As you can see here, we can use an endoscope to look inside the sinus and find the implant. And in this case, the implant is removed from inside the nose with a FES surgery, because again, this implant migrated to the osteomeatal complex. And you can see that the implant is seen here and removed from the nose. This is something that I want to emphasize. As you can see, this was taken immediately after the surgery. You can see that this implant is located here. It took about 1 week for this patient to come to me after he was referred by his dentist. And if I would have done the surgery by the initial imaging, you can see that the position of the implant has changed. It's almost 1 week. It has changed. If I would perform the surgery, I would look for him here, and I wouldn't find it. So it is very important to have the imaging before the surgery itself, CT before the surgery, and sometimes also during. If we have a failing implant, then we just remove the implant, and this is enough for resolution. And if we have an osteomeatal complex obstruction, then we use the regular sinusitis protocol. We can perform FES or the DIVA implant. So this brings us to the end of the treatment rationale, and you can see this is the summary of the treatment rationale. And if you want, you can take a picture of this workflow, or afterwards you can see it on in the website, in the Paltop Academy website. And always remember, you need to explain to the patient. You need to do a proper diagnosis, because otherwise, if you're not prepared, then it is an excuse. And if something happened, and complications do happen sometimes, you need to have immediate treatment. Immediate treatment in this case. And just to finish up, we are in, as we said, very special times. And I just want to show you this short video clip of a movie I like very much. It was made in 2011, starring Tom Cruise and you can see him driving through New York here, and he arrives to Times Square. Basically, this is a dream, but look how realistic this situation is for these times. Okay, so this concludes our presentation, and now I will go through your questions and try to answer some of them. Let's see the first question. So I see Karamakan Kuru is asking, what is your procedure in management of large membrane perforations? What is the procedure I use for management of large membrane perforations? Well, large is something very different from case to case. It depends how large, but as a general rule of thumb, there are many techniques to fix perforations, but usually I will use membranes and PRF. But the most important thing I can tell you about membrane perforations, it's very important to release the membrane around the perforation. Don't leave the perforation as you see it and then leave it connected at one side, because doesn't matter what you do. If the membrane is still connected to part of the sinus, as you try to manage the perforation will get larger. So this is one thing that is very important. First of all, I finish the separation, because sometimes clinicians, they see a perforation and okay, they don't touch it because they don't want it to be larger. So they try to manage it while it is connected partially. Don't do it. Release it and then fix the perforation. Now, if it is a large perforation and I feel that I cannot close it properly and feel that it will protect the bone graft in not going inside the sinus, then I also abort the procedure. I tell the patients, as I told you in the presentation, I tell the patients there is a chance that I will not finish the procedure. I wait 3-4 months and do it again. But for me, if it's a large perforation, I would place a collagen membrane, sometimes 2 membranes, and if I feel that this case needs also some added protection, I would use also PRF, and that's it. This is how I deal with perforations. I don't do sutures of the membrane. I don't believe in this. It's usually, if you have a really thick membrane, you can suture it, but this is minority of the cases, and most of the cases, if you start suturing the membrane, you will tear it more, and I think make it simple is the best solution, because then you start to have complications. If something doesn't go wrong with the sinus, better not do it. Abort it, wait, and do it afterwards. This is what I think. Okay, so another question. What is my experience with the success rates in the implants in the sinus? Is there a difference between implant brands? Okay. So I don't believe there is a large difference between implant brands that we know that have experience more than 5-7 years. I in generally don't use any medical device that has a very short-term experience, and if these are implants that are used for a long time and prove themselves. I don't think there is a difference in the success rate, but I do think there is a difference in the success rate that depends on the experience of the clinician. What I mean that the experience of the clinician, if you're used to use one kind of system, and you move to the other system and you're not experienced, then you can have some issues. That depends what kind of implant you're using, which is an active implant. If you were using the advanced, let's say advanced plus, which is a more active implant, and then you switch to the regular implants, which need other protocols of drilling, then you can have stability issues. So you need to have experience in the specific type of implant you're using. Okay, so this is something very, very critical. But if you're asking me between the brands, then this was my answer. Thank you, Fakistas from Greece. Thank you for your note. Thank you, Bernard. Bernard Dahan, thank you very much. I saw your presentation 2 days ago, and it was really, really a nice presentation, an amazing presentation. Thank you. Okay, so Barbara Klein is asking a very good question, and can you explain how you use the small segment of bone to repair the cyst removal hole? So basically this is a double window technique, which you thin the bone and you leave a small window, a small area of bone in the middle of the window, and what you do, you gently lift this window like a window, then you penetrate the membrane, and then you place back this window. You need some experience to use this technique, and it is not easily done. But this is the technique I'm using. Sometimes you cannot use this bone, and you have a membrane perforation, and then you deal this case as any membrane perforation. This is depends on the size of the perforation you get, and of course you explain the patient, you have the cyst, I need to remove the cyst, I may not be able to finish the procedure, and same, explain before, otherwise it is an excuse afterwards. So explain, but I do need to emphasize this technique, and what I'm showing you is something, it's not easy to perform it, and it's better if you don't have a lot of experience in it. Even if you have experience in this, it's hard to do it. So usually these cases are managed before the surgery, before or during, or doing it together as I showed you, together with FAST, or doing remove the cyst and do the surgery afterwards. It's not something like, yeah, okay, this is easy to do, let's do it in all cases. So it's something to remember. And another question, why did you use a cortical block to close the sinus window? So this refers to the large defect of the failed sinus which had multiple surgeries, and I decided to take a ramus bone graft and close the defect. The reason I was doing that, because it was a very large defect. It was a defect about 2 centimeters. It was from, I think, from the canine to the first or second molar, and from my clinical feeling. If you have a very large defect, you can imagine a very large window you open in the sinus, then you will not get cortical bone if you just put bone chips. You have a very good chance that if you don't close it, as I show you, you will have extravasation of bone chips outside of the sinus. It will get infected, and you will not get a good cortical bone to get stabilization of the implants in the second. I don't feel like I would just put bone chips and that's it. This is not a case to put bone chips and that's it, because it is very, very. It is a large defect. This is the reason. It is a large defect. In general, what I wanted to tell you that I'm using very small windows. It's much harder to perform the procedure. As the windows is smaller, it's harder to perform the procedure. But I got used to it, and I do very small windows. I use special tools which are really micro tools. I'm not using the big spoons to elevate the membrane, and I do it very gently. I remove. I can get access to the all the dimensions of the sinus, and you get less complications. From my experience, as the windows is smaller, it is better. So let's see the next question. Do you ever use antibiotics mixed with a graft material? The answer is no. The answer is no. How long do you keep the patient on antibiotics in case of infection before deciding to remove the graft? Okay, so this is a very good question. If I have any symptoms I don't like, you know, the symptoms, the patient after a week calls you, after 2 weeks, I was feeling better, and then I feel some fullness, and then it started to swallow again. First thing I do, I don't tell him, okay, take antibiotics, let's meet after 2 weeks and see how you feel. First thing I do a CT scan. In the CT scan, I see if there is a problem that I recognize. If I see everything is okay, the bone graft is in place, I don't have overfill, everything looks as I expect it to be, then I would give him antibiotics, nasal congestions, nasal rinses, and I will give him antibiotics for 10 days, even 2 weeks, and expect to have an improvement, okay? Again, it is very important what you see in the CT scan. If you see the OMC is open and you don't have congestion of the sinus, and you see this fluid level and you see the OMC is open, I will give him antibiotics and wait. But if I see something I don't like in the sinus, then I will usually give him antibiotics for 2-3 days, just so he would be on antibiotics, and start the protocol I was showing you. Start with a very small incision, exploration, doing saline rinses very gently, trying to feel what's the situation there. And again, if I see it's a, let's say I see there's bone graft all over the sinus, then there's no point in waiting. If I see a problem, I treat the problem. I don't wait. I go, I clean the sinus, and that's it. Don't wait. Immediate intervention. This is the most important thing when you have a sinus complication, because afterwards, if it is a long-standing, it's really, really hard to treat it. What bone filler do you use? I am using xenograft mixed with allograft. I use 1 to 3 ratio. I'm using xenograft with the allograft, and you don't have to use the allograft. I use the allograft because of the osteogenic potential. It is a theoretic thing. You can use only xenograft, but you need something that will stabilize the membrane for a long time until osteogenesis starts. So this is what I'm using. Next question from Manila, Svetlana Malabed is asking, what are your thoughts with regards to the palatal pedicle flap technique in the closure of the oro-antral communication? Well, this is definitely an option, but you need to remember that patients suffer from this technique. You leave connective tissue exposed on the palatal side. You need to do to put an obturator there just for the healing time, and they usually suffer very much. And another thing, you need to remember that this area the tissue is not of good quality. There's usually infection there. The tissue is very, very thin, scarred tissue. And if you do another procedure of a flap, I don't like these cases, because flaps usually have the tendency to fail if the conditions are not perfect. Okay, so then if you have a failed flap in this case, you're in a bigger trouble than you were before. Okay, so these cases, I don't use the pedicle flaps. There are certain indications doing so, but in these cases, I cannot remember doing this technique. Let's see the next question. Okay, so next question is, what do you think? Which one is safer than other, the open sinus lifting procedure or closed procedure with a DIVA implant? In general, as you go for minimal invasive, when you have a complication, it is more localized complication. You can have a failing implant, but it is more localized. Okay, but as you use minimal invasive techniques, the minimal invasive techniques are more technique sensitive. Okay, so this is also something you need to remember. If you are doing an open sinus lifts and then you change your technique, then you may have some adaptation time. Okay, and you need to practice. Maybe go to the cadaver room. Maybe work on some models. But in general, as you do a more minimal invasive procedure, it's much better because it is localized. Okay. So this is my opinion on this. Of course, there are cases you cannot do a minimal invasive procedure. You need to do an open sinus lift if you have very little available bone. So DIVA implants are very good, but it's not a total solution in all cases. Thank you, Alex, my dear colleague. Ideal. Okay, so Carla is asking, ideal healing time, how long for stability? Okay, so a sinus lift, usually I would wait 9 months. This is the classic time I would wait. You can maybe do some discount if you have a lot of available bone and the bone quality is very good and you feel the implant is very stable. Maybe you can shorten it, maybe six months you also can do it, but the classical, I would wait for 9 months. There's a tendency to do everything faster and do everything in one stage. My personal belief is that I better be safe than sorry. I don't want to. Don't want to save 3 months for the patient, and then something goes wrong, and then I ask myself, if I waited 9 months, maybe it would be better. I go for safe. This is something that I would like my physician to do for me, and so this is what I do for my patients. I go for safe because I know when you have a complication, starting all over again from the beginning is much harder than doing it the right way the first time. Maybe waiting another 2 or 3 months. So don't hurry up. We have time. Okay, so next question is which material you secure area of harvesting bone block? Okay, so I suppose you mean the gel foam. It's just a cellulose gel foam you use. It should be sterile cellulose, and it's just for hemostatic purposes and filling the void, filling the area, and that's it. That's it. I do rinse it with hexacapron to have less bleeding. The gel foam absorbs the hexacapron and also absorbs there is less bleeding potential in these cases. What antiseptic solution do I use? The antiseptic solution I will use is just mouth rinses with chlorhexidine. During the procedure itself, I don't use any material. You just need to keep the sterile, use almost only saline, and you shouldn't have any problem. Which bone level for your indication to use external sinus procedure? Okay, so I suppose the question is if I use an open sinus lift or a closed sinus lift. Well, there was a classification that was used that's around after more than 7 to 8 millimeters you can use closed, and between 3 millimeters and 7 millimeters you need to open the sinus but do one-stage procedure. If you have less than 3 millimeters, do a second stage, do a two-stage procedure. Well, this is the classic classification. But now, at the last years, what we are doing, we decide by the primary stability of the implants. If I know that I can achieve primary stability of an implant, I can perform a two-stage procedure. If I have a bone less than 3 millimeters, I will not do a closed sinus lift. You can do a closed sinus lift if you are experienced and you have a good stability of the bone. If you have more than 3 millimeters of bone available. But again, better be safe than sorry. So you need to have experience to do it in 3 millimeters, okay? But it's possible if you're using, let's say, the Diva implants. You can do it, but again, you need to have primary stability. Okay, so let's see the next question. There is another question here about the buccal fat pad. Okay, if I remove the buccal fat, does it have any influence on proportion of the face? The answer is no, because it is a deep fat pad, and you don't remove large amounts of fat. It doesn't have any influence on external looks. Okay, so let me just review and see if there is another thing that I didn't answer. There's another question about the movement of the mucus over the time period of the video of the time period. It is about 10 times faster. The video of the mucus of the cilia moving inside the sinus is about 10 times faster. So I think we've reached the end of the presentation, and as I can see, I think we answered all questions. Thank you for listening. Thank you for being here with us. I really hope we will all be safe, healthy, and we will finish this period the best as we can, and meet again in big meetings, meet in front. So thank you very much, and happy holidays. It's Easter, Pesach, so be safe. Okay, bye-bye.